Well, we're here on Healthcare Unfiltered. This is a special episode with the most famous, what do we call you, Marty? The most famous Chicago guy, national guy, international guy, but I think you are most famous for being one of my attendings and mentors when I was a fellow at Northwestern. So it is an honor and privilege to have you on my humble podcast to talk about mentorship and your presidency of ASH, as well as what's happening in the world of leukemia. So I could not be more excited and honored that you granted me this access. So Martin Tallman, welcome to the Healthcare Unfiltered.
Thank you, Shadi. It's my pleasure and a true privilege, and thank you for having me.
So there may be a couple of people out there in the world that don't know you. And for those two people who might be listening and don't know who Marty Tallman is, maybe a little bit about you.
A little bit about me. I am a Chicagoan. I went to medical school here in Chicago, undergraduate at the University of Michigan, where actually for a year, I'm not sure you know this, Shadi, I was in the School of Music.
I did not know that.
As a cellist. And I had a wonderful year, but I learned I wasn't that good. I wasn't that good.
I see that you succeeded very well in music.
I didn't think I was that good. I could have gotten a job, I think, in a symphony, but I didn't want that for my vocation. I wanted that for my avocation. So I switched to a pre-med program, graduated, went to medical school, and I did my internship residency and chief residency at Evanston Hospital, part of Northwestern. And then I went to Seattle for my fellowship. And then I came back to Northwestern, where I was in the faculty for 21 years, very wonderful 21 years. And then I had a wonderful job opportunity at Sloan Kettering to become the chief of the leukemia service. And they made me just a wonderful offer, and I thought it was a fantastic opportunity. And I've been there for 12 years. When one of my sons had the audacity with his wife to have a baby.
Terrible.
How dare him?
So you're a grandfather.
I'm a grandfather, a first-term grandfather. It's wonderful. And that was enough for my wife to convince her to move back.
So I take it your son and his wife, they live in Chicago?
They live in Chicago.
So you're back at Northwestern to your roots.
I'm back at Northwestern. Very happy to be there. Wonderful institution.
And in addition to seeing leukemia patients, Marty, do you have other administrative responsibilities at Northwestern?
I'm professor of medicine. I'm seeing patients, doing some teaching. I'll be doing a lot of teaching. And they asked me to be very involved in mentorship and career development, which I suppose after 12 years as a chief at Sloan Kettering, I ought to know something about career development.
You know, that's a good segue. What does that mean? Like, in other words, where do you start? How do you, in that role, how are you going to execute on that mission? What's your vision? How are you going to actually work on career development and mentorship? I presume this is for junior faculty who are joining the institution. What are your plans? Like, what are you going to do to make sure that this actually happens?
I think it's a wonderful opportunity for junior faculty and for me. And I hope to meet with each junior faculty that wants to meet and see if I can help identify a mentor if they don't have a mentor. And I may serve as a mentor for some of the leukemia faculty, but otherwise help foster a career development plan and mostly make sure that they've aligned themselves with an appropriate mentor themselves.
So what are the criteria of a good mentor? Like, who is a good mentor?
I think a good mentor should be an expert in the field of the mentee. It should be a person that is enthusiastic about fostering the career development of a junior faculty. It should be someone that is willing to give up some opportunities that they can pass to that mentee. I think it's someone that is someone that is anxious to impart knowledge and experience and guide the career of the junior faculty. It should be a good listener. It should be someone that's anxious to listen, someone with whom for whom the mentee has respect as a mentor. I think those are the main qualities.
You know, I love the fact that you mentioned give up certain opportunities. I mean, I think this is really critical, and it's probably why mentors, in my opinion, need to be senior level, because at some point you want to be over the fact that you need to be a first author or something like that on these papers, and you have to pass these along. And you're not going to pass these along if you're still an associate professor, I would think, but maybe I'm wrong.
You're right. I think that's true in any leadership position. The focus, to a certain extent, is whether you're a chief, whether you're a department chair, whether you're a mentor, the focus changes a little bit. Until that time, you're in that kind of a position. We all promote ourselves and our own careers, give talks, write papers, write reviews. But when you become a mentor or a chief or a leader in any leadership position, you have to be willing, secure enough, as you suggest, to relinquish some opportunities and relinquish those opportunities to the mentee.
In your, Martin, you've had a long career in terms of folks that you've trained and mentored, and like, what advice do you give to mentees, to folks who really want to try to build a career? And I think it's getting harder and harder. I mean, getting funding is harder, research is harder. There's a lot. It's just not the same as 20 years ago. What advice would you give them?
I think one important fact is to be as focused as you can. You know, there's a little bit of, it's said with tongue in cheek, you get rewarded in academic medicine for knowing more and more about less and less.
So you are basically, you're an expert only in AML M7. That still exists?
Well, you have to know about all of AML, but there's a little bit of truth to that. If you become an expert in even a very narrow field, people recognize you as an expert. You write in the field, that's how you become an expert. And then anytime someone wants to talk on AML M7, they call you. So I think there's some truth to that.
What got you into leukemia? I mean, you went to medical school. What got you into oncology? And then after oncology, what got you into leukemia?
My path was very clear. When I was an intern, there were two hematologists, both gone now, who I thought were the smartest, most wonderful, compassionate physicians. They were both leukemia hematologists, and hematology was one of my early rotations. And I liked looking at the cells under the microscope. And one of them, early in that rotation, was going to the ASH meeting. This was in 1980.
Who was that? Can you share his name?
His name was Dr. Steve Curtides. And he said, I'm going to the ASH meeting, and I was an intern. He said, would you like to join me? I think it was in Washington, D.C., if I'm correct, at the Shoreham Hotel. At that time, the entire meeting was in one hotel, if you can imagine that. Hard to believe. And I went with him, and I've only missed one ASH meeting since 1980. That was when one of my kids was born in 1986. Her birthday is December 8th, and I'm usually not home for her birthday.
Who's the other hematologist that influenced you?
Dr. Harry Miller.
So these two folks you met during residency, and it made you decide you want to do hemonc.
Yes. And I think about it to this day. And I wonder if they were cardiologists, would I be in cardiology? I think it's interesting how an individual can influence. I think that's actually not uncommon. That an individual faculty member at an institution is inspiring to a student or to a house officer, and that guides them in that direction.
I mean, I was influenced by you, by Leo Gordon, by Jane Winter, and by Steve Rosen, and all I could think about was lymphoma and leukemia. And you're right. I mean, sometimes you wonder if you were influenced by, well, Bill Gradishar is not that influential. I mean, of course, hopefully he's listening to this. Then what got you to the Hutch? I mean, obviously the Hutch is the mecca for transplant and leukemia. Was it difficult to get to? Like, how did you decide to go to Seattle?
I knew not only since I was an intern that I wanted to be a hematologist, I always wanted to study and be involved in the care of patients with AML. I branched out a little bit. Of course, I have interest in ALL and monocytic leukemia and a side interest in hairy cell. But I always wanted, since my internship, to be involved in AML and the study of AML. I've never wavered from that. And I finished my chief residency, and my feeling was that Seattle was at the time, and I think still is, a leading institution in both transplant and leukemia. And I had a wonderful experience there. Fantastic.
You were trained by Fred Applebaum?
I was, and I regard him as one of my main mentors.
Okay. And I'm curious, Marty, about what you mentioned, looking at cells under the microscope. There is not a formal training for us, as at least at the time, for fellows with pathology, frankly. I would just go with you or with somebody else and just go to the hematopathology lab and take a look at the cells with the pathologists. Is that changing? Like, do you not feel that hemonc fellows should get really more formal mentorship or training in hematopathology or in pathology in general?
I think it's a good point, and I think that a number of fellows and house officers decide to elect to rotate in hematopathology. I think that's more common than it ever has been in the past. But I think it's important. I essentially never treat a patient without looking at the slides with the pathologist under the microscope myself. And there were some times during the height of COVID that it was very difficult. But in general, I always look at the slides under the microscope with the hematopathologist together.
Have you ever disagreed with the hematopathologist? Like, I mean, you look at them because you want to learn and just take a look at them, or do you feel that you may actually alert the hematopathologist certain nuances that they may not be aware of?
Both, but particularly the latter. They're very anxious. Good hematopathologists are very anxious to hear about the disease, the chronicity of the disease, associated medical problems that may have influenced the disease. So I think they're very anxious. Is there splenomegaly, for example? I think all of these things a good hematopathologist wants to know to arrive at a firm diagnosis.
I'm just taking your picture right now for Twitter at some point, just in case for these folks who are listening. So then how did you become an ASH president? I mean, it's not like, I mean, is this something you wanted to, or does it come organically? I presume it's not something when you went into training You said, I want to be the president of the American Society of Hematology.
No, not at all.
How did this happen?
You first run for vice president. And if you're elected vice president, then you become president-elect and then president each year's duration. And someone or several individuals nominate you, and it's vetted through the nominating committee. And they ask you if you're interested to run. And I told them it'd be a pleasure and a privilege. It's a great privilege to be the president of ASH.
So the nominating committee comes to you and says, we think that you would be a good president of ASH. And then you could say yay or nay, and you said yes.
Yes.
Why did you say yes? Like what is it? I'd like to know a day in your life as a ASH president. I mean, do you stop seeing patients? Do you have to cut on practice? What does it mean to be president of ASH? And I voted for you, by the way, so you owe me. I'm from Chicago, so my vote is not free. You haven't paid yet.
I appreciate that. No, it's a great privilege to be asked if you're interested in running for president and being elected by your peers to lead the society for a year. Let me say, when you're the president of ASH, you have a lot of responsibilities, but almost none of the responsibilities are done by yourself. They're all facilitated by an amazing ASH staff, amazing group of people, led by a brilliant, really brilliant administrator, Marty Liggett, who's been the executive director of the ASH for many years. And she coordinates a fantastic staff of people. I actually ran the first year for vice president, and I lost. You may remember I lost to my good friend Stephanie Lee. I was very happy for her, though. She did a wonderful job. She had a challenging job because that was at the height of COVID when it was completely virtual, 2020. And I ran again and won. And I was delighted. We had a half virtual and half in person, as you may remember.
Who was your opponent?
My opponent, good question. I think it was David Bodine.
Mm-hmm. Mm-hmm. So, take me through how this, like, what were you doing? In other words, was it 1 day a week where it's only for ASH and the other 4 days for your practice? Did you have to change your schedule to accommodate this? Or I guess I'm trying to educate listeners how much of that position is a figure for the world of hematology as a leader versus how much it's time consuming in terms of day-to-day and signing papers and doing stuff and talking to the press and talking to other folks, you know?
Yes, it's really both. First of all, the broad responsibilities are to represent the interests of the membership and advocate for the interests of the membership. It should function like a government, but it functions much better than our government because things get done and they get done well.
I see the government is doing so well nowadays.
Well, ASH, I wish we had the leadership of ASH running our government.
Yeah, me too.
The only major change, it is quite a busy year. In terms of my own schedule, I did stop attending on the inpatient service. I still saw patients in my clinic at Sloan Kettering, but I did stop attending because I would say that there's responsibilities that need to be attended to almost every day, every other day. There are signing documents, advocacy responsibilities, meetings with congressmen, members of Congress, other representatives. There's lots of, you attend virtually all of the many standing committee meetings. And there's a lot of them. And so that's quite time consuming.
Part of me thinks it should be more than 1 year. It's so hard to do anything in 1 year. I know it's busy, but I feel like, sometimes if you have like an agenda and you want to, don't you think 1 year is too short?
Well, it is a busy year. It is busy. There's certain responsibilities. Again, I would say every day, every other day, throughout the year, and it certainly gives other individuals an opportunity to lead the society. So I think 1 year is good length.
So one of the things that we see, I got share this with you as a former ASH president. There's always this many cries in terms of the cost of submitting abstracts to ASH. It's a non-refundable fee. I think it started at $60. It's now probably $85. So if you submit 20 abstracts, you're talking almost $2,000 that is non-refundable for the abstracts you submit. And there's always the suggestion that this is unnecessary. It's too much. At some point, the abstracts were free. You don't need to pay for submission, especially for trainees and junior folks that, that's a lot of money. As an ASH president, did this come up in your term? Is this the kind of thing that people bring up to you and say, hey, we're hearing a lot about this. Should we make a change? Are you involved in this, or is this not something that you were involved in? And do you think it should change?
It certainly is the kind of thing that people can write the president of ASH, and then I would refer them to the appropriate committee, the appropriate individual, the appropriate ASH staff. And then if it's a serious issue, and many times it's brought before the executive committee, and the executive committee renders a decision. So it certainly is an issue which I've heard about. I have to admit that I'm glad that it didn't come up in my tenure as the ASH president. And it's something that I know people have talked about and debated, and it is worth the executive committee addressing, I think.
What are your thoughts on it? Any thoughts on it? I mean, if you were in charge, would you have an opinion into what your thoughts would be?
I don't know how important that fee is to the Blood Journal or the other journals. Certainly a source of revenue, and I'm not exactly sure how important a source of revenue is. So I think we need more information before we make a decision, but it's worth discussing.
Yeah, and the cost of attending these meetings is becoming a little bit too steep. When you were elected to be an ASH president, did they ask you for a theme? Like, your presidency, did they have like a theme or a vision that you need to accomplish? Did you have that?
Didn't ask for a theme, but when you run for the vice president, which will lead to the presidency, you may remember that you do fill out a little bit of a biography, and they ask a number of questions. And they do ask you to address your vision. And I indicated that I thought that there are three major sort of pillars of ASH I think of. Number one, research. Number two, advocacy. And number three, education. And I was, of course, enthusiastic about representing the interests of the members in all those three areas. But I was always impressed that I think the major feature that is the major issue that is facing ASH members and all of medicine is the rapid pace of progress. I mean, there is so much coming so quickly, and it's hard to take it all in, and it's hard to implement all of the new knowledge. And that's why I thought that was an important area of focus, that we should really focus on education. And I think we did.
Yeah, I mean, there's so many drugs that get approved all the time, and there's always on Twitter, on social media, as you know, there's always the debate about certain trials and drugs and approvals and things like that. You've become fairly more active on social media compared to a couple of years back. What are your thoughts on what you see? Sometimes you chime in, sometimes I think you just watch from a distance and just listen to the dialogue. What are your thoughts, observations on social media and the discussions you see about trials and data?
I think social media is fantastic. I think Twitter is terrific. I chime in when I think I have something either intelligent or to contribute. I'm not sure I contribute everything that's intelligent, but when I have something I think I can make a contribution, I chime in. But I think it is a fantastic source of medical knowledge about, as you know well, you hear about new drugs very quickly on Twitter. People post information about questions and debates about cases, and new publications we hear about quickly, and people's opinions, their evaluation of new publications. So I think it's a wonderful source of education. By the way, you should note, as I'm sure you do, I chime in not only on medicine, I chime in on classical music, and particularly when it has to do with the cello.
I have not seen that. I see Leon, the cancer center director there, always posting about certain things pertaining to classic music and symphony and things like that.
Yes, I think he's very knowledgeable about classical music, and he enjoys it very much.
I actually wonder sometimes, I haven't asked him that question, like, how much does he really know, or does he like look things up and then he posts them? I need to ask him that.
My sense is that he really knows the.
Oh, he knows amazing about that.
Yeah,
it's crazy. So let's talk a little bit about leukemia. You've been taking care of leukemia patients for about 3 decades. I'm not saying you're old, Marty. Don't worry.
Thank you.
Yeah, don't worry. But when I was taking care of patients with you, and for the record, for listeners, when I was Marty's fellow, he did not perform any bone marrow biopsy and aspirate on his own whatsoever. I did all of the bone marrow biopsies and aspirates. You remember that?
You became very adept at it.
Yes, because every time you were supposed to do a bone marrow, you said you had like a tennis elbow, and somehow you're like, I can't do it. I have a tennis elbow.
I don't know about every time, but I did have tennis elbow. In fact, I got an injection of hydrocortisone.
Yes.
Before that, I actually had an MRI. It was legitimate. I had bad tennis elbow.
I think they always happen the day of the bone marrow biopsy, though. I mean, I don't know what. but I mean, leukemia is a completely different disease. I mean, at the time, it was 7 and 3 and HIDAC and allotransplant, which was not easy to do. And look where we are now. I mean, take me through the history, what you have noticed in terms of what you were doing for leukemia patients back then and what you're doing now.
You're exactly right. The initial induction therapy that we use today when we give classical conventional induction was described really in 1973. And for the next 44 years, there were no sustained drug approvals. I say no sustained drug approvals because you know that gemtuzumab was approved, but it was withdrawn. So I shouldn't say there was no approvals, there was one approval, but essentially there were no sustained approved drugs for 44 years. And just as you said, the approach was very similar, so-called one size fits all. And that was 7 and 3, followed by HIDAC or intensive consolidation. And for as many patients as were eligible, allogeneic transplant, which was a difficult procedure then. It's still difficult, but I think it's much easier than it ever has been. So there was no sustained drug approvals between 1973 and 2017. All of a sudden in 2017, we saw the approval of midostaurin, FLT3 inhibitor. And since then, there have been 9 others. So between 2017 and 2023, there have been 10 new drugs that have been approved for patients with AML. Some frontline for frontline use and some for relapsed and refractory patients. And it's become more interesting, more exciting, the care of patients with AML, but I think in many ways more difficult. They have many more choices, but that leads to more difficult decisions. And I think it can cause a lot of consternation among leukemia physicians, certainly constitutes a lot of debate. We now, of course, there's a huge move in many ways away from chemotherapy, away from cytotoxic chemotherapy toward more targeted therapy. And I think the most important of the 10 drugs is venetoclax, which, as you know, is combined with hypomethylating agents. And I think it's created a whole new field of opportunities in the field of AML. Many new drugs are being combined with hypomethylating agents plus venetoclax. And I think that that regimen will form as the basis for maybe even replacing, certainly it's replaced 7 and 3 in many older adults who are not fit for chemotherapy. No question about that. It's a new standard of care. But I think it may emerge as a new standard of care in older adults who are candidates for chemotherapy, particularly those with unfavorable cytogenetics and molecular genetics. And in fact, I'd go so far as to say it may replace 7 and 3 in younger patients who are suitable candidates for intensive chemotherapy, but who have very unfavorable cytogenetics, those with TP53 mutation, complex cytogenetics. So, yes.
Do you need a prospective randomized controlled trials to replace the 7 and 3 with the venetoclax HMA?
I think so, yes. I think that will be needed. Whether it can be done or will be done, as I said, is a difficult question, but I think it should be done, yes.
One of the critiques that I saw recently on social media about the CPX compound was that the trial, the NEJM paper, I believe, patients who did not respond, or the consolidation, I guess, therapy was 5 and 2, not always HiDAC in those patients. And the thought process was, we really don't do 5 and 2. After 7 and 3, you do HiDAC for these patients. You don't really do 5 and 2 after 7 and 3. So I'm curious if you've seen that criticism, if this is, I recall when I was a fellow, you taught me I could do 5 and 2 for some patients.
Older adults.
Especially the older ones, that as a consolidation. So they go into CR, and I've had several patients with you who've done 5 and 2, but I'm not sure the data or the evidence on this. But have you seen that criticism? Any thought on this? Because that's why CPX apparently was superior, and a lot of folks contested that this is not really the appropriate design.
Yeah, let me, if I may, with great respect, I want to correct you on one fact, and that is that you talk about the initial randomized phase 3 study, correct?
Yes.
It was published, I think, in the JCO, not the New England Journal.
Maybe it was JCO, so I apologize if it was, yes. Well, you always corrected me, so I stand corrected. JCO, NEJM, doesn't matter. It's People Magazine.
With great respect, I say that. No, it's true in older adults in the cooperative groups. I think all 3 of the cooperative groups often had trials. It was not clear that high-dose cytarabine was effective in older adults, and you couldn't deliver true high-dose cytarabine. You have to deliver less than high-dose, maybe intermediate dose. But I think I'm not sure it's clear that older adults do better with high dose or intermediate dose cytarabine than a repeat of induction. So yes, there was a time when it was certainly acceptable to repeat induction in older adults as consolidation. So I have seen that criticism, and I'm not sure how valid it is.
It's so you repeat the induction, just an abbreviated induction, 5 and 2. I mean, part of the reason, Marty, this is, I think, a timely question is not just necessarily the criticism itself, but we don't have we don't we don't have a study to answer every single question that we have in medicine. And I don't know how we reconcile that. So, for example, there are no studies that I'm aware of, prospective studies, that compare 5 and 2 to HiDAC or to intermediate dose cytarabine. But still, people did it. So, what are your thoughts? I mean, how do we really proceed forward when we don't have enough resources and trials to answer every question?
Well, permit me with great respect, again,
I made a mistake.
I say this with great respect as a friend and colleague. It wasn't, I'm trying to be delicate.
Hey, it's unfiltered. Go for it, buddy.
Right, that's right, it's unfiltered. So Alan Burnett in the JCO and the former MRC, now the NCRI in the UK, did a randomized trial of 3 grams per meter squared consolidation twice a day, day 1, 3, 5, versus 1.5 grams intermediate dose, day 1, 3, 5, twice a day. And they found essentially there was no difference. There was essentially no difference in outcome. Now, and there's been a move toward giving less than 3 grams per meter squared, except maybe in core binding factor leukemias where there's some suggestive evidence. Even that evidence is not very strong. Some suggestive evidence that 3 grams per meter squared is beneficial compared to lower doses.
How about the 5 and 2?
If I'm correct, in ECOG, I am correct. In ECOG, we never used 5 and 2. When we repeated the induction, we gave another cycle of 7 and 3 to older adults. I think that was from the Alliance, formerly the Cancer and Leukemia Group B. If I'm correct, their protocols often repeated 5 and 2, I think to diminish the potential toxicity. But in ECOG, we always gave a repeat of induction, 7 and 3.
Marty, leukemia is becoming such a, like, you've got like 20 leukemias because everything now is on the molecular level, from an NPM to FLT to IDH2 to all of these molecular subclassification of leukemia. How relevant is morphology today? And, what you taught me back in the day under the microscope, and, does it matter anymore?
No, it's interesting. When I hear about a new leukemia patient, I used to, and I'm still somewhat interested in the white count, want to know the age, certainly want to know comorbidities. But the first thing that comes to my mind when someone says I have a new patient with AML is my immediate reaction is what are the genetics? What are the cytogenetics and what are the molecular genetics? And in a way, more so than the white count, more so than the age of the patient, because it's really the genetics that drive the course of the disease. Not only, of course, important in diagnosis and prognosis, but it really drives the disease. You get a feel for what the course of the disease is going to be based on the cytogenetics and molecular genetics. I think morphology is still important. I think you still want to look at the bone marrow to know if there are associated eosinophilia, basophilia, dysplasia, other changes in the bone structure. So I think morphology is still important. But I acknowledge the first thing that I want that comes to my mind are what are the genetics, cytogenetics, and molecular genetics.
So, but I mean, as you're a clinical trialist, and some of your studies were published in the most prestigious journals in the world, NEJM and others. As leukemia, already a rare disease, becomes ultra rare with all of these differences, how are we still able to do prospective large phase 3 randomized controlled trial to understand new drugs replacing older drugs, empower it to be able to to detect these differences, or do you think clinical trial design is changing in some of these ultra-rare diseases?
I think that there's never been a more exciting time, as you and I have suggested. There's never been more drugs, potential for drug combinations. I think it's never been more important to collaborate. And I think there's never been such good collaboration as there is today, not only within the United States, but even across the Atlantic and Pacific to other parts of the world. Having said that, I do agree that I think there's a great interest in developing new designs, new statistical ways of analyzing statistically the results to see if you can identify new findings with less patients. So, I think that's important. But I think there's never been more collaboration. So I think, but it certainly would be helpful to be able to make important observations with less patients.
Yeah. I mean, I'm just trying to think, for example, let's say you want to design a study today for IDH or for FLT3 positive AML patients. I mean, how many AML patients you need to screen to find the FLT3 and then randomize, and what would be the control arm and I just think in the cooperative groups, when you guys sit and thinking of the designing the next trial for AML, I presume all of these conversations are happening, and I don't know how you reach a consensus.
Well, they are happening. There's no question. And the new big one will be called the MyeloMatch protocol, which has taken many years to design, but hopefully it's coming to fruition very soon.
When did you start designing this?
A number of years ago. I was not directly involved in its design, but it's a number of years ago, I think 4 or 5 years ago. So this has taken a long time, but it involves all 3 cooperative groups, which always is it requires consensus to the design for the design.
Are you able to share the question being asked?
No, first of all, there are numerous questions. There are numerous sort of protocols and sub-protocols. So it's a complicated design, and I'll wait till it's publicized.
And this is in frontline.
Online.
And then in relapse disease, when you look at relapse disease AML as a clinical trialist, are you also segmenting AML in the relapse setting based on the molecular subtype, or are you trying to lump things together?
Well, we're trying to identify them in design trials based on molecular genetics, because many of the new drugs, menin inhibitors, certain antibody immunoconjugates are targeted. So we're trying to enrich protocols, patient populations for those abnormalities.
How was your ASH meeting? Anything excited you at the ASH meeting? The menin inhibitor was pretty, I think it was seems like the hot stuff going on.
Yep, I think that was exciting. There's a lot of interest still in magrolimab, the anti-CD47 antibody. And there were a number of combinations, 5-azacitidine or decitabine plus venetoclax plus a third agent. There were many of those trials. So I think those were among the most exciting.
This has been really exciting. We talked about mentorship, leadership, your career, AML, ASH.
We're not done, are we?
No, we're never going to be done unless you tell me we're done. I mean, you're the boss. See, the nice thing about Healthcare Unfiltered, Marty, is I don't need to edit anything. It just basically everybody is going to hear I made 2 mistakes. Thank you very much. Everybody is going to hear that you just asked me if you're done, and I said whenever you want. But everybody's going to know that I did all of your bone marrows and you refuse to do any bone marrow.
Didn't ask me how my tennis game is.
I'm presuming you're still having tennis elbow.
No more tennis elbow, but I'm into pickleball now.
You are?
Yeah.
How is that going?
Great. Great game. Do you play?
No, I don't have any time. I work too much.
You have too many podcasts.
Not really, but you know, as listeners will know, they are going to, you know, pre-order and purchase my book, as you will as well.
Happy to.
That's good marketing right there. And you're gonna write a review on Amazon.
Be happy to.
I like it. Well, Marty Tallman, thank you so much for visiting with me on Healthcare Unfiltered. It's such an honor and a privilege to have you.
My privilege.